Hi everybody, my name is Anil Karapurkar. I am an endovascular neurosurgeon. I was a professor of neurosurgery at the KM Hospital and am now a consultant at the Bridge Candy Hospital. Today I thought I would talk about cerebral angiography for subarachnoid hemorrhage. Basically, we have to start with a neuro cath lab. It may be a monoplane, it may be a biplane. I have, in an earlier video, explained the basics of the neuro lab. So today we will talk about it essentially as regards cerebral angiography. So what you have on your screen now is a typical monoplane cath lab, and this is a biplane cath lab. The advantage of a biplane cath lab is that you can do fluoroscopy and roadmap in two planes simultaneously. You can acquire images, that is, make runs in two planes simultaneously. Advantage is you reduce exposure and you reduce the volume of contrast that you use, and of course, you improve the safety of what you are doing. This is a hybrid lab. In fact, the HN hospital where I also sometimes work is equipped with this hybrid. In the hybrid lab, we can also do surgery if required. So endovascular part is done by us, and if some intervention is required, like for instance, embolization of spinal tumor like a hemangioma, so you embolize and then the surgeon can operate. This is also used by peripheral guys for hepatic surgery and cardiac surgery. Also, I think they do some procedures. The disadvantage we have found with the hybrid lab is that the table movements are very slow. You give your command and the table starts moving a couple of seconds later. The C-arm movements also are relatively slow. So that is a disadvantage of the hybrid lab. Otherwise, the image quality, etc., is the same. The I always say that if you want to get sharp images, you should keep the head right up against the eye. If you are using a monoplane, you can do that. If you are using a biplane, you cannot. The NeuroLab also has a headrest which is specific for the neuro work. The cardiac labs are square. The table end is square. And one should use an injector as far as possible. Last time I had shown an angiomat, which is a Philips injector. This is a Medrad. Medrad is made by an independent company, and it can be used with any of the labs. The advantage of using an injector is that you can fit it the the head of the injector can be fixed to the table railing. So then it moves back and forth, and you don't have the clutter of the foot pedestal of the injector. Uh, you can do this cerebral angiography under local or general. If the patient is restless, I prefer general anesthesia. One advantage is that if you need to subtract, and subtraction is important for us, there is no movement, so the subtraction is very sharp, and pixel shift can be very easily done. One other thing is you can hold the breath. So under local anesthesia, you have to tell the patient stop breathing, don't move. But under anesthesia, you can tell the anesthetist to stop the respiration, and you can get much sharper pictures. This is especially true for 3D because it has to make, in some machines, it has to make two turns. The first turn is non-subtracted, the second is with contrast. So it has to make full turns 360 degrees back and forth. So during this time, there should be no movement if you want to have good subtraction. Next is heparin. Do you use heparin? For those who are not reusing anything, you need not use heparin, and if you are experienced. But if you are not experienced, you are beginning, it is better to use heparin. If the aneurysm is very dirty or very regular, it may be safer not to use. Otherwise, for a diagnostic angiogram, we usually use 1000 units of heparin, and that is for diagnostic angiogram. For embolization, if it is to be done in the same sitting, after the diagnostic angiogram, we give 3000 units IV, or usually we ask the anesthetist to give it so that they keep track of what has been given. If an FD or a stent is to be used, of course, we use 5000. And as far as possible, one should use activated clotting time to make a baseline reading, and then from time to time take the reading as required. If a balloon is being used, we try and keep the ACT around 300, 350. And after 1 hour, the half-life of heparin being 1 hour, after 1 hour, it may need to be topped up. So usually we ask the anesthetist to keep track of that, and they keep topping it up as required. And in the irrigation also, we have 1000 units of heparin. Access, you can have femoral, and now I have never done radial. We have done brachial in some occasions, and my colleague Rakesh has done some radials, but we have been doing femoral. But now there are more and more people who are doing radial. So you can have a 4F or a 5F diagnostic catheter. I always like to keep the catheter at the common carotid, go to the lateral view, do a roadmap. You can save the roadmap for future use and enter the internal carotid under vision, because there may be some disease at the bifurcation. So we should not dislodge the plug. So we torque the catheter away from the plug, or we use a wire to advance. The same is true for subclavian. We make a roadmap of the subclavian, and then we enter with a wire or with the catheter. If you have a biplane unit, today what is standard is you do lateral and town. So one shoot for lateral and town, then do the 3D. And after the 3D, choose the angle at which you see the aneurysm best. Always have two. Always have a working position with two angles. Because in one plane, when you are working, you may think, "Arey, going beautifully." You look at the other plane, it has gone somewhere else. So you have to be very careful that you always have two working positions. And if you have this locking mechanism, two fixed positions, you can fix those two positions, and the C arm or the L arm automatically goes to those two positions. So this can be done on a 2D if you have a biplane. If you have a monoplane, you don't have the luxury of a 3D rotation. Then you have to perforce do multiple shoots, unless you have seen where the aneurysm is located on a previously done CTA or MRA. If you have a CTA or MRA, you know more or less where the aneurysm is, then you need not spend so much time. But if you have not been able to see any aneurysm, then you have to go through the gamut. So what I used to do was put the C arm on the lateral, first for the lateral, AP, LAO, so lateral, LAO, AP. AP is 0 caudal, craniocaudal. RAO, then town, go to town, town RAO, town, town LAO. Then go to, if you've still not seen anything, go to caudal, caudal, LAO, caudal, caudal RAO. So usually the town is at 40°. The obliques are usually at 35. You can keep it at 40, whatever you think is right. Caudal is usually 20, because usually it is difficult to go beyond 20. 22 is the maximum that you can go to. But 20 caudal is good enough. So if the aneurysm is directed upwards, caudal view is good. If the aneurysm is directed downwards, town view is good. But of course, you may have to go through everything. So you have to repeat that on the other side. And if required, do a cross compression. So especially for a giant aneurysm, for an ACOM aneurysm, you have to do cross compression, compressing the other carotid. And don't forget that sometimes the dural AV fistula may cause subarachnoid hemorrhage or intercerebral hemorrhage. So always remember that you should also do an external carotid angiogram. So either do a selective external or do a common, but at least make sure that you're not missing a dural fistula. Similarly, one should also do bilateral vertebral angiograms because the pica may be missed on on a single vertebral angiogram. Even if it is a non-dominant vertebral, one should do a bilateral vertebral angiogram. And if the aneurysm is not seen up to that point, when you are doing the lateral head, always include C2. At least the C1 and C2 should be included so that you don't miss if there is a low pica. Rarely, I have not seen that now, but 20 years ago, the pica aneurysm was difficult to visualize, and we have sometimes made simultaneous injections into both vertebral arteries. So for that, either you make two injections with two hands, or there used to be a Y connector, a Y with a single thing which goes to the so two catheters, two Y, and one to the syringe. I have not used. I had that in Apollo Hospital, but I have not used that connector for a long time. But I'm sure it is available in the market. Acquisition 2 frames per second is enough. Rarely in a giant aneurysm, you are not able to see where exactly the neck of the aneurysm is. In that case, a 6 frames per second may be necessary. And if you are not getting good pictures, patient is restless, induce anesthesia and do it under GA. Or sedate the patient. But many times with sedation, in fact, the patient becomes more restless. And if in doubt, do it under anesthesia. So for subarachnoid hemorrhage, one should do 6 vessel angiography: bilateral carotid, bilateral vertebral, bilateral external carotid. And it is also necessary to do this because in 20% of patients, there may be more than one aneurysm. But usually it is only one aneurysm which bleeds at a time. Even if the patient has multiple aneurysms, they do not bleed at the same time. And of course, if you have one of these congenital conditions like Marfan's or polycystic kidney, Ehlers-Danlos, then there is a higher risk of multiple aneurysms. So if there are multiple aneurysms, how do you know which is the culprit? It can be very difficult, and you will be wrong. There are some points which indicate which is the one which has ruptured. So the acute on the headache, when it at this onset, where was it? Was it in the left temporal? Then it could be an MCA. If it was suboccipital and neck pain, it could be posterior fossa. If it is frontal, it may be ACOM. Not necessarily, but it can be an indicator. We have had patients with ACOM aneurysm who come with sudden onset paraparesis which has recovered. A third nerve palsy, of course, is PCOM. Acute vertigo, ataxia, diplopia can be a hallmark of posterior circulation. So these are clinical signs. Uh, the other way to determine is the aneurysm, if there are multiple, which is the one which is irregular, which is the larger of the aneurysms, which one has a nipple. If all of them are similar, then usually, at least in our experience, the most common to rupture is ACOM. But there are reports who have said that they have found PCOM to have ruptured more often. And ACOM, PCOM, and then the others have more or less the same incidence. But ACOM, at least in our experience, has been the one which has bled most often. Imaging, if a CT is done early, within a few hours or on day 1 or day 2, blood may be located around the aneurysm. But many times you'll find that on day 4, if a CT is done, the blood is all gone. On the other hand, MRI may not be very accurate on day 1 or day 2, but even up to 2 weeks, you can see blood around the, on the side of the bleed. It may be in the sulci or it may be in the Sylvian fissure, but it is often seen on the side of the aneurysm on flare and on SWI. As far as possible, you should determine which is the one which has ruptured and treat it. But if you cannot, if in doubt, then treat all. We had one patient who had bilateral MCA and ACOM aneurysm, I think 3 times. So, in on 2 occasions, we treated one MCA and ACOM in the same sitting, and the opposite MCA a couple of days later. So you may have to decide which ones to treat first and leave the second site for maybe 3 or 4 days later. The other common problem, conundrum is this an infundibulum or is this a, an aneurysm? Sometimes it can be really very difficult to determine is this an infundibulum or an aneurysm. So infundibulums are common on the posterior communicator and on the anterior choroidal. So here again you have to do multiple angles to try and separate the precom from the fundus. But if they are very close together, sometimes it may be very difficult. 3D may help resolve this, but without 3D, it can be quite difficult to decide finally, is this an infundibulum or is that an aneurysm? Blister aneurysms. These are again often missed on non-3D. So you have to be very careful if you see any irregularity, especially in the typical locations. So which are these typical locations? The dorsal wall of the supraclinoid ICA, the A1, the P1, the P1, P2 and P2, P3 junction, and the vertebral artery PICA junction. These are of course the typical locations, but it can happen anywhere. The blister aneurysms can happen anywhere, but these are the typical, the most common being the dorsal wall of the supraclinoid ICA. A1 and P1 being the next most common. Dissecting aneurysms. Again, these can be missed because the locations are unusual. They are not at bifurcations. So here again, the typical locations are vertebral PICA origin junction, the supraclinoid ICA, the A1, and the distal PICA. We have quite a number of dissecting aneurysm on distal PICA. So how do you distinguish a dissecting aneurysm? Usually there is no neck. Usually there is some irregularity of the circumference of the artery at the aneurysm, proximal and distal. There may be some stenosis of the artery proximal to the aneurysm. So one should think of these things when looking at, so analyze very carefully. And I have seen that one should always try and magnify. So I forgot to tell you that when we do those oblique views, we take the down and lateral with the full head. But when we do oblique views, we try and zoom so that we can see better. So especially for these dissecting aneurysms, for blister aneurysms, zooming, it may be a digital zoom or it may be photographic zoom, but if you zoom and see, it is always better. Similarly, when we record, also we should try and record. Now you've done a very careful angiogram, you demonstrated the ACOM, you demonstrated the PCOM on both sides, you've done the cross compression and you still don't see an aneurysm. And you've included the C2, you've included the upper cervical spine. So many times if there's some angiogram doesn't show anything intracranial, do bilateral subclavian to see whether there is something in the cervical spine. So if nothing is found, very rarely there may be a spinal subarachnoid hemorrhage, which we have had patients who have come with typical what look like intracranial hemorrhage, acute headache, neck pain, vomiting, diplopia, and to our surprise, it's not intracranial but spinal. Because when we go back and ask the patient, did you have backache, did you have neck pain? They would say that they had neck pain, which is not typical suboccipital with intracranial, but cervical spine pain with a cervical subarachnoid hemorrhage, or spinal dorsal pain or lumbar pain with dorsal or lumbar spinal AVM. So there we have asked for in one patient we asked for X-ray and found scalloping of the vertebra. If in doubt, do an MRI of the spine. When do you repeat or do you not repeat? If it is a perimesencephalic bleed, and if you find that your good angiogram is negative, definitely ruled out a posterior circulation aneurysm, or a PCOM aneurysm, or P1, P2, P3 aneurysm, then you may not repeat it. But at other locations, some form of imaging should be repeated. CTA, MRA, or DSA. To my mind, DSA is always more reliable, but there are some who will tell you that a CTA will give as good images. But the CTA, to my mind, is not as good for intracranial aneurysms because the skull base, the clivus, the sphenoid body, the sphenoid wings obscure aneurysms. So posterior circulation aneurysm, basilar, vertebral, uh, superior cerebellar, ICAs, distal ICAs may be missed on a CTA because the skull obscures what you want to see. MCA similarly, aneurysm may be obscured by the sphenoid wing, ophthalmic by the anterior clinoid. But MRA, especially if it is a contrast MRA, usually one does not miss these aneurysms. So either when to be repeated, 2 to 4 weeks. There are some who say up to 6 weeks. So there is no clear guideline as to when you should repeat it. But one should repeat a subarachnoid hemorrhage. We ourselves have made it a rule that we repeat the angiogram at least at 4 weeks. But some do it at 10 days, some do it at 1 month. If the repeat angiogram again, including everything, is negative, you have ruled out spinal subarachnoid hemorrhage, then the long-term prognosis is good. Why are aneurysms missed? There is really no explanation. But it is thought that maybe the aneurysm somehow neck got thrombosed, the thrombus got absorbed and the aneurysm reopened. There may be spasm. That can happen. With spasm, one may not see the aneurysm. Inadequate exploration, meaning you have not looked at the images very carefully. You have not done zoomed pictures. You have not looked at them very carefully. So it's inadequate exploration or interpretation. And blood blister aneurysms can be missed. So one should be careful about blood blister. And those are the ones which are dangerous, which bleed again and again. I also find many of us just do the angiogram and go away, and the technician copies the everything onto the uh, CD and gives it to the patient. I don't think that is right. We have done so much time, we've taken so much effort to do the angiogram. We should take some more effort for archiving. So we should annotate because many times it is impossible to make out on the lateral view. Is this the right or is this the left? So one should always annotate, right, on the angiogram. One should always make some still images also, so that when the CD is given, the CD should have the movies as well as the still images. For the operating surgeon or even for you at a later date, when you want to go back and see it, if you have still an images and subtracted, non-subtracted still images, it is very useful. So annotate, and when giving for prints, you can even make paper printout. Prints, try and zoom so that again the image quality is better, you get more information. So when especially the obliques, try and zoom so that, or when you see the pathology, try and zoom the images so that you get a better quality. So I think with a good angiogram, we should not miss subarachnoid hemorrhage because after all, they do come back with a rebleed. So thank you for your attention.